Meeting on Thursday, 10th of August, 10 a.m. So before we start, I just want to remind you that we are being videographed and audio recorded and everything, so therefore make sure you are, don't show any sensitive information on the screens of your mobile phone or laptops. Thank you. And this is our custom to start the meeting, introducing yourselves. So I will start. So when you do introduce yourself, can you please press the mic so that everyone could hear it? So it's also a training if you ever want to ask questions, which are welcome. So you can also do the same thing. Okay, I am Councillor Paul Egil-Shelvan, Chair of Health and Wellbeing Board.
Remember to do as I'm told. I'm Graham Sires. I'm a GP in Alnwick. I am clinical lead at Place for the ICB and Vice Chair here.
Good morning, I'm Pam Lee. I'm a public health consultant here at the Council and I'm representing Jill, who's our DPH today.
Good morning, I'm Wendy Patterson. I'm County Councillor for Long Houghton Division and also the portfolio holder of Adult Wellbeing.
Liz Simpson, County Councillor for Newbiggin.
Laura Whittaker, I'm Associate Director for Learning Disability and Autism Services within Cumbria Northumberland Tyne-and-Wear NHS Trust. Attending today on behalf of Cherie McCartney. Thank you.
Vicky McFarlane-Reid, Director of Business Development and Enterprise, Newcastle Hospitals.
Hilary Snowden, representing Northumberland Local Medical Committee.
Debbie Nugent, Health Watch Northumberland.
Peter Stanfield, also Health Watch Northumberland, attending my first meeting, having recently replaced David Thompson as the new chair.
Anne Everton, I'm a consultant in pharmacy services to the Public Health Department here at the Council.
Morning, I'm Jeff Watson. I'm a councillor and a cabinet member with a portfolio for Healthy Lives.
Good morning, Abby Conway. I'm the Chief Exec of Citizens Advice Northumberland, representing the VCS Collaborative Thriving Together.
Good morning, I'm Ross Wiggum. I'm a Director at Northumbria Healthcare and I'm here covering for Alistair Blair today, who normally attends these.
Good morning, I am Sam Renison. I'm the Chief Superintendent for Northumberland and North Tyneside and Northern Area Command.
Good morning, everyone. I'm Graham Binning. I'm the Deputy Chief Fire Officer at Northumberland Fire and Rescue Service.
Good morning. I'm Veronica Jones, County Councillor for Ponteland West and portfolio holder for Public Health and Inequalities.
I'm Rob Murphy, Director of Housing and Planning at Northumberland.
Peter Stanfield, who is coming for the first time, and welcome into your new role. And also Abby Conway, Chief Executive of Citizen Advice Northumberland, but representing here, Thriving Together. Thank you. Welcome, Abby, as well. Okay. First item, apologies for absence.
Apologies from Alistair Blair, Neil Bradley, Cherie McCartney, Rachel Mitchison, Jill O'Neill, Graham Writer, Councillor Renna Thompson, Christine Wardlaw and Ashley Eyston.
Thank you, Leslie. So, minutes of the previous meeting. I think the previous meeting was held on 8th June 2023. So the minutes are here. Can I propose this a true record of the meeting that happened. Yes, thank you. Disclosures of interest. Anyone has anything, any disclosure to do? I see none, so let's move on. So the first major item today is annual report from our senior coroner, Andrew.
Karen Lampton.
So, oh, yes, sorry.
Oh, sorry, I got distracted with the sign. I'll check out the microphone as well. I've just been kindly given one by Councillor Watson. Yes, I'm here today to represent Andrew Hetherington, who unfortunately can't be with yourselves today because he's in court. Are you happy for me to continue?
Do you have any slides to present?
No,
okay.
I don't.
Please do that.
Thank you so much. Well, thank you for the invitation to attend the board. Okay. Morning, everyone. It is nice to see people actually when you're speaking, so I think it's a better idea to sit here. So thank you everyone for the invitation to attend the board today, and I'm here to represent Andrew Hetherington, who's Senior Coroner for Northumberland, but unfortunately can't be with everyone because he's in court at the moment. My name's Karen Lampton. I'm an interim head of service and I'm currently based within the Public Health, Inequalities and Stronger Communities Directorate, and part of my role is to look after and be part of the coroner service, amongst a few other things as well. So a little bit of background, which I hope is useful to you. So the coroner service in Northumberland is judicially led by Andrew Hetherington. He's our senior coroner. And he's been in post since October 2020. And since that date, the coroner service in the county has gone through a number of quite significant changes, and I would like to say quite significant improvement as well. So the coroner service is based in County Hall, Morpeth, where the coroner has a court, a dedicated court, purpose-built, which is not always the case for every coroner in the country. So we're very lucky to have the resource that we have in the county. The court is supported by dedicated accommodation. We have an accommodation suite which consists of offices for the coroner's office's staff and the administration staff, along with a dedicated jury room, a family room, a waiting room and a meeting room which can be utilised by legal teams. Because of our location in County Hall, we're blessed to be able to breathe in and breathe out as a coroner service as and when required, really depending on the size of the inquest that we're hosting. We also have access to the accommodation suite, which is just along where the conference rooms are, which we often use in some of our larger cases as well. But fundamentally, the accommodation that we are able to utilise in the county now enables us to provide a really high-level service. And the accommodation is actually quite an important part of the coroner service and the experience that bereavement families will ultimately have as part of that process. So our coroner is supported by 6 assistant coroners in the county. They're employed on a sessional basis, so they have a number of days per annum that they will work for Northumberland as an assistant coroner. And they are there to provide cover for the coroner, for planned leave, for training, and also to provide resilience, which is really key and critical in the coroner service. And if it wasn't apparent before, it certainly is post-pandemic, where the coroner service was placed under a level of stress as a consequence of the pandemic. And also the coroner plays a leading role in terms of mass fatalities and planning such as that. So the resilience of the coroner service is incredibly important, just in case we need, in the case of a quite a catastrophic situation, we need to really stretch and flex that coroner service, which thankfully we haven't had to in Northumberland. But you always have to be prepared. So it's worth noting that our coroner, our senior coroner and our assistant coroners are appointed by but not employed by the local authority. That's a really key sentence that I wanted to share with everyone today. You may know that already, but the relevance of that sentence is that it demonstrates complete judicial impartiality, and that's incredibly important in the role of a coroner, and especially important to our bereaved families who have cause to use the coroner service. The investigation work of the coroner is supported by 4 coroner's officers who are employed by Northumbria Police, but located in County Hall, Morpeth. And the administrative support for the coroner services is provided by 2 officers who are salaried by NCC. I always like to outline that to colleagues when I talk about the coroner service, because I think it sort of puts on the record it's a team effort. It's a collaboration between the local authority and the police. And that relationship between those parties has to be incredibly strong. It's a little bit of a triangle, actually: coroner, police and local authority. And the secret to any successful coroner service is the strength of those 3 connections and that mutual respect that we have. The local authority plays a significant role. I have a registration and coroner support service manager who is the local authority linchpin between the coroner service, and I sit in that family of local authority officers who have a role to have oversight and responsibility for the coroner service in my head of service role. So the role and purpose of the coroner: we have to have one. It's a legal requirement that the local authority must indemnify a coroner service. So we must have a coroner. And it's the role of the coroner to investigate where necessary if a death is deemed to be violent or unnatural, if it's unknown, and where the person has died in state detention or custody. And in those latter cases, we must sit by law with a jury as part of that inquest. So given that Northumberland, we have a number of hospital facilities where detention is required as part of mental health provision, and also we have HMP Northumberland. So we have quite a footprint across the county whereby state detention rules will dictate that we must sit with a jury inquest. And that's one of the reasons why when we designed the court in County Hall, we really pressed the point about having some dedicated resource for those jury inquests that undoubtedly we'll have to host over the course of each year. But basically, the coroner's role is it's not to determine matters of civil or criminal liability, but it's really a look to understand who died, where, when and how. It's those 4 key themes. So I'm here today to talk a little bit about the annual report of the Senior Coroner, which I know you will all have had sight of, and I hope you've found it quite a compelling and informative read. It's good practice for a Senior Coroner to produce an annual report. It's not a legal requirement, but it's good practice for the coroner to do so. And what I just want to add today is that not every Senior Coroner across England and Wales will do this. So we have Andrew Hetherington in post now. He's been there since 2020, and it is his practice to deliver an annual report. But it's a really good tool for a formal communication to be relayed to stakeholders, to the local authority, about the work of the service, some challenges that the service may have, and some achievements that they have managed to achieve over the course of that year. But it sets out with clarity the operational side of the business. So one of the headlines that we'll often put in an annual report, that the service has a requirement under the Ministry of Justice to provide an annual statistical return. And that return is delivered on a calendar year basis, not a financial year basis. They're open and transparent statistics. They're an interesting read. They're available for every jurisdiction across England and Wales, and they're on gov.uk if you go and have a look at them. The statistics for 2022 were published in May. They'll always come out each May for the previous calendar year, and you'll be able to have a look and compare and contrast if that's something which is of interest to you, the work of the coroner. The statistics will centre around caseload, volume of postmortems, waiting times for families in terms of the case to be concluded. So just some headlines for our statistics for Northumberland for the year 2022. So in 2022, we had 3,714 deaths occurred in the county of Northumberland, of which just over 2,000 were referred to the coroner. We had 2,028 which were referred to the coroner. Now, that doesn't always manifest in just over 2,000 inquests which are heard in court, because the investigation process will dictate that a number of those referrals are discontinued because a natural cause of death is determined during the course of that process, and that's when the coroner stops and the matter is referred to the registration service for the death to be registered as a natural cause death. So we had just over 2,000 cases referred to the coroner, but from that, 270 inquests were opened. So it gives you a little flavour as to how it starts off at a high figure and it tapers down to a much lower one in terms of what actually ends up as an inquest in court. From the referrals to the coroner, we completed 732 post-mortem investigations. Those post-mortem investigations are a necessary part at times of the investigation process, because sometimes a cause of death can only be determined by a post-mortem. And in the case of our statistics from last year, we had cause to commission 732 post-mortems. That's always quite an interesting statistic for everybody connected with the coroner service. From a local authority point of view, we often have an interest because there is a significant cost associated with post-mortem investigation as well. But our post-mortem rate as a percentage of the referrals that we received last year sits at 35%. If we look at our regional average, and when I talk about the regional average, I'll refer to Tyne and Wear and Northumberland, that's sat at 40%, so we're just a little bit lower than that. The time taken to process an inquest in the county currently sits at 26.5 weeks. Now, that compares at 30 weeks on a national level. So we are sitting a little bit below that national level. And you must bear in mind that we're taking an average there. So while some inquests will conclude quickly, some might wait a long time for a court inquest to take place. And that is the average that we've taken to input into our statistics. A really impressive statistic that I wanted to share with colleagues today was our caseload over 12 months is an annual statistic that the Chief Coroner of England and Wales has a natural interest and a very keen interest in, because that will often dictate a level of potential satisfaction from our bereaved families in terms of how their loved one's death is investigated. We have no cases over 12 months in Northumberland. That's a real achievement for the county, and it's certainly not usual, is what I would say. We have some authorities across England and Wales where that caseload will be quite high. In some cases, it might be 3 figures. So to have a nil rate of cases over 12 months is really quite impressive. And I'll talk about that a little bit later. Out of interest, you may not know this, but the Treasurer has a responsibility to investigate treasure. We always think the coroner is connected with death and death only, but that very old-fashioned judicial role of coroner, which goes back to medieval times actually, still holds with it a responsibility to investigate treasure. And we are a county of treasure, Northumberland, and it goes back to our historical legacy of Lindisfarne and Vikings and Romans, and we will occasionally have some treasure finds. They are reported to the coroner, believe it or not. And we had 8 this year. You'll typically find that treasure inquests take place across the east coast of England. So I hope that's an interesting statistic for you. We saw a slight increase in deaths reported to the coroner compared to last year, 2021, where we had 1,918. And since 2019, we've had a real significant increase, I think, in the number of deaths referred to the coroner. That's a 17% increase. We think there's a few reasons for that. Very happy now that we have great confidence that the right deaths are captured and referred to the coroner. This has been delivered, I believe, through increased engagement with our NHS colleagues. The coroner is very visible. The coroner likes to communicate and set in place good communication channels with NHS colleagues and stakeholders. We have strong engagement with the medical examiner based at NSEC. And we have strict compliance with the Notification of Death Regulations 2019, and they came in to specify with great black and white clarity which deaths came to the coroner. On the back of that, we commissioned a new IT system for the coroner service where the notification of deaths was prescribed by an online portal which enabled our NHS colleagues and anybody who had a requirement, our police colleagues as well, to refer a death to the coroner, to be able to do that 24/7 and not have to wait until the office opened at 8 a.m. and make that phone call when other things might have really gathered pace and your day could be losing track a little bit. So we feel that the clarity of communication, the engagement that the coroner has made with stakeholders who refer deaths to the coroner, and along with the systems that are in place to facilitate that, have strengthened the referrals and the clarity of knowledge around that. And also, as NSEC continues to grow and expand, that in turn will mean that our death rate in the county will grow and expand as well. And that has a factor on the volume of caseload that the coroner has. It's worth noting, for the avoidance of any doubt, that for any deaths that occur in Northumberland, whether that person might be a resident of Newcastle or North Tyneside, but if they pass away in the county of Northumberland, then that death must come to the coroner here. So it's not where you live, it's where the death occurs. And that's sometimes a fact that people don't realise. And I very much understand how you would assume it was maybe where you live and not where the death occurs. So we've got that interesting statistic of a growing caseload of deaths which are coming through. And that's going to be a watching brief and something that the coroner will report on each year. So trends and patterns from the 2022 operating year, which there's a footprint in Andrew's report for you to look at in more depth. We've picked up on some of the suicide conclusions in Northumberland. A very brief summary over the last 4 years. In 2019, we had 18 suicide conclusions. In 2020, we had 30. In 2021, we had 44. And in 2022, we had 21. Coroner believes that there's a number of explanations regarding that little increase that we've seen in suicide conclusions, but one of the really important consequences that may drive that increase is something called the Maughan case, and I'm not sure if people are familiar with that, but it's a case which was heard in 2020, and it's Maughan versus the Senior Coroner for Oxfordshire, which really changed the standard of proof in suicide inquest cases. So previously, all conclusions in coronial inquests had been determined on the beyond all reasonable doubt standard. And the Maughan case has changed that to rule that all coronial inquests should be determined on the civil standard of proof, which is the balance of probabilities. And I think that in itself is quite a simple explanation as to why those coronial suicide statistics may change, because that is quite that was quite a monumental case in the coroner world in terms of that suicide investigation. There's also a train of thought that COVID-19, the pandemic, may have impacted on suicide statistics, but that link is unclear and not quantified. But over the course of the last 3 years, in some inquests that our coroner has heard, where a conclusion of suicide has been returned, it wasn't uncommon for the deceased prior to death to have expressed anguish regarding COVID and pandemic, and feelings of loneliness and despair. And albeit that is not directly linked to that suicide conclusion, it has been discussed in court. It's been part of that investigation. So I've touched upon COVID, and I've also touched upon that lack of backlog of cases over 12 months. And I think it's good to maybe join up those two themes and talk about how we operated through COVID as a service. So we functioned as near normal as we possibly could. That was really important to keep things moving and to stop any backlogs occurring and to support our bereaved families. I don't think anybody can think of anything worse to lose a loved one, have a pandemic, and not be able to have that final conclusion. The inquest is sometimes that final piece of closure for families. It's really, really important. It's not just a fact-finding legal course of action. It's very often some mental and emotional closure for families as well. And to keep that hanging for a long time can be very detrimental. So, unlike many other services across the country, we continue to operate as near normal. We were able to do that because we've got excellent court facilities provided by Northumberland County Council. And we've got excellent court facilities provided by the council because we were able to contribute and shape the design of that. And that goes a very long way to having an excellent coroner service. We've got a big court. We could stretch out, we could grow, we could work within guidance and regulations in terms of COVID safety, where we could have socially distant court hearings in person. We also have brilliant technology and tech, so we are able to dial people in via the screen. It saves on very important NHS time, and we continue to do that in terms of witness and evidence, and it enables families to also access court if they're not here. So we've had some international dial-ins from families who wanted to be part of that investigation but didn't live in the country. But that all went towards business as near normal operation during COVID. And I want to put on the record that that wasn't usual practice across many coroner services. As a consequence, Andrew and I were invited to, and we did present in London in March 2023, we were invited to speak at the Chief Coroner's annual Local Authority Conference held in Westminster Hall, London, to talk about how we operated through pandemic, the good practice, the great collaboration between coroner, local authority and police, and to really set the bar as a standard of good practice. And it was great to be acknowledged actually by the Chief Coroner to have that national platform to speak. So I've touched upon the Chief Coroner there. Our current Chief Coroner is His Honour Judge Thomas Teague KC, and he is currently Chief Coroner of England and Wales and will be until the end of this calendar year. The Chief Coroner is still quite a new office to hold, and it was brought in by the Coroners and Justice Act 2009, which was enacted in 2013. We've had 3 Chief Coroners so far nationally. They really are a key part of leadership of the Coroner Service and have taken some significant steps in terms of modernisation, consistency and standards. We have an excellent relationship with the Chief Coroner in Northumberland. We welcomed the Chief Coroner to the county in February 2023 as part of his welfare tour, which he has conducted on a national basis across England and Wales. He met with Councillor Glenn Sanderson, the leader, Jill O'Neill, our Director of Public Health at the time, and some key council officers and the cabal of coroners' officer staff that we have, and our colleagues in Northumbria Police as well. He was incredibly impressed by the court facilities that we offer. He was incredibly impressed by County Hall and the accessibility to such simple, maybe things that you don't notice, like the access to a restaurant and a fresh coffee and a restroom and a private space for families to be in. I was really, really pleased with that, as along with the signage and the clarity of the clarity which wraps around our service that we offer to families when they come into County Hall. So it's excellent to have that accreditation in a way. So next steps for the Coroner Service. We've got ongoing dialogue with Northumbria Police regarding Coroner's Officer resource. We think it's a little bit light touch and we'd like to have that bolstered. We certainly don't feel that we have consistency with our local authority colleagues across Tyne and Wear. We have the second highest caseload of coroner cases in Tyne and Wear and Northumberland, but we have the lowest number of Coroner's officers, and that's a very blunt statistic to share. But we are in dialogue, active and constructive dialogue with Northumbria Police to hopefully resolve that and reach a conclusion. The service continues to work with the registration service. We're co-located. That's a huge step to have that proximity and that regular contact between the coroner and the registrars. We're very focused on having the most streamlined, simple, straightforward process of death registration, death investigation for our residents and for our bereaved families who have cause to use our service. The co-location will certainly help that. We'd like to take some steps to collaborate further and really knit together the two services in terms of how that process flows, so families don't really see a break between coroner and registrars. It just goes all of the way through. We're in active conversations with our Northumbria NHS Trust friends to develop non-invasive post-mortem facilities. This is a real challenge. It's quite expensive to do, but I'm sure everybody can appreciate how, for a family who lose a loved one, where a post-mortem is required to determine that cause of death, to have the opportunity, the facility and the ability to have a non-invasive post-mortem, which is a scanning solution, it is much better to have what is now really an older-fashioned method of an invasive post-mortem. And we have an active conversation regarding that. We're also speaking to our NHS colleagues about body storage facilities and the costs which are associated with that. Very much with a drive to achieve best value. We're continuing to work with our colleagues at NSEC and our medical examiner colleagues. The medical examiner system comes onto the statute book in April 2024, which will see it rolled out across community settings as well as hospital settings. The medical examiner is a very long-awaited and, you could argue, overdue service, consistent universal support to bring it in, where really it brings up that scrutiny bar in terms of cause of death for all cases which don't go to the coroner. And the medical examiner service was initially mooted on the back of the Harold Shipman inquiry, and I think we can all date stamp that and understand how long ago that took place. But finally, those steps are galvanised, are in place, and we're starting to see the benefits of that. We think that the medical examiner implementation across the board will see a change in the caseload to coroners. It might see a reduction in the caseload to coroners, but it might increase the complexity of those cases. But albeit that the objective of the medical examiner service will be to really deliver a high quality scrutiny of all deaths that occur. So just in conclusion, I touched upon the journey that the Coroner Service has taken since 2020. It's really been quite rapid. Prior to myself joining Northumberland County Council and Andrew Hetherington taking his judicial role, our Coroner Service, our court was in Berwick. Our coroner's offices were based at Ashington Police Station and our admin staff were based in North Tyneside and Berwick. So you'll see that we've unified and brought those very much together in a central administrative hub where those services can be delivered to the right extent, to the right quality level, and we're doing that now. I'm really confident in saying that the service, it meets the needs of bereaved families and we deliver consistency across the service, which is super important. I'm delighted that in the last tranche of local government reorganisation, the NCC reorganisation, that the Coroner Service was assigned to the Public Health Inequalities and Stronger Communities Directorate. I think the benefits of the location of the service being within that directorate really are quite engaging and, dare I say, exciting, Pam. We've already started to have some conversation and dialogue. We're making those new connections between our senior coroner and colleagues like Pam in relation to the public health agenda and that intelligence that can be driven out of the coroner service. And as a result, one of those early wins that Pam helped engineer is that our coroner is now actively engaging with the crisis care, suicide prevention and mental health strategic partnership. So we've got that firm connection which is there. And just finally today, regretfully Andrew couldn't be here to speak to you. He's in court and has a meeting clash which couldn't be changed. But he does really want to put his thanks on the record to Northumberland County Council and colleagues who he works with on a daily basis, NHS, police, for the excellent collaborative strides that have been taken to deliver what is really an excellent service for Northumberland and one which will continue to evolve and grow. So I'm very happy to pause and take any questions that you may have, which hopefully I can answer. If not, I'll take them away. Thank you.
Thank you very much, Karen. In fact, if I may note, this is the first time such a report is being presented to the Health and Wellbeing Board. And thank you very much for your time. In fact, the presentation was comprehensive and very clear, and the report, even the report is well written. I mean, in the sense, lots of facts, interesting facts. And I just want to thank you before you go, because you have worked during the lockdown period as nearly normal as possible. So that's something hands up. I don't think it happened across England. It's in this county. And also, finally, my remark is that at the end, Andrew says that there is a positive support for coroner service in general from the county. You also elaborated. We are very happy to continue supporting it and see the service grow. Okay, with that, I'll stop and then leave the floor for any questions. Any questions? Abby? Yeah.
Could I just ask around the suicide rates? Obviously, you indicated why it had increased, but then obviously last year it decreased. Is there any thoughts or conclusions as to why that?
Thanks, Abby. It's a great logical question. We think that it's there was a little bit of a spike in 2021, wasn't there? And it's decreased down. It was 40-something down to 20-something across the 2 years. We think it was a slight catch-up situation regarding COVID, so that was achieved and realised during that period of time. So we think it was attributed to that. It's outlined a little bit in more detail in Andrew's report. I haven't gone through that granular detail today, but we think it's attributed to that, Abby.
Also, Abby, just to say, our numbers are quite low, but our rates are high. So what often happens is that our rate changes quite quickly. Just on kind of one or two cases, our rate can change quite a lot. But I think what Karen alluded to about the work that we're doing, kind of more upstream, is really very innovative, because that does not happen in other places. I know in other places we have quite a lot of trouble engaging with the coroner's service sometimes. So we're hoping that that will help.
Thank you. I thought it was a really interesting report. From a primary care point of view, the portal is fantastic.
Brilliant.
So thank you for that. I mean, most portals that we have to use in primary care make life more difficult.
Yeah.
And yours doesn't.
Good.
So you've won there. Thank you. I was curious about some of the conclusions about the emergency hospitals and our setup there. I suspect there are people across borders, but I didn't see a reduction in North Tyneside's rates, which one would expect if NSEC was taking North Tyneside's patients instead of Newcastle taking North Tyneside's patients. So I was just a bit wary of the conclusions, but I don't think materially it affects the report particularly, but it would just be useful to reflect on that a little bit. I know we've got Newcastle hospitals here, Vicky's here. I would also be interested, you mentioned that a suicide occurs based on where the person dies. Therefore, do our suicide rates get reflected about any of our residents that end up in a Newcastle hospital and die there?
Yeah.
And do we pick those up correctly?
Yes, we do.
Perfect. Okay. There was some quite useful detail about the work around young people and the tragic case of the young person suicide. And I know the mental health team you know, how that links up is actually crucial, because this should all be about
Yeah.
prevention, shouldn't it?
Yes, yes.
And I think we just need to be assured that
Yeah.
that's working well.
It is.
Yeah.
And it can always be...
Sorry, Pam, go on.
Sorry, I was going to say, I think it can always be improved, you know, because of the nature of the situation, but I think it can always be improved. But I think what we now have is quite a good, strong partnership and link to do that.
Yeah,
Thank you.
we do. We had that first meeting back in the spring, actually, Pam, didn't we? And I think it was quite apparent that there were some amazing connections to make between the work that Pam does in public health and Andrew as coroner for Northumberland. And I think in the report as well, he's gone into quite a lot of detail, hasn't he, about a specific case, and also mentioned about the Regulation 28 report, which was an outcome of that, where he's going to has made a formal recommendation regarding future practice and care, etc. And that is one of the roles of the senior coroner, in terms of recommendation to prevent future deaths and preserve life. So that's always an outcome from the coronial work which takes place that many people don't have that awareness of.
Two final points. One, which almost doesn't need to be stated, was just the fact that I didn't see the word inequalities anywhere in the report.
Right. Okay.
I know that public health are very involved anyway,
Yes.
but actually that theme should be running through everything that we're thinking about.
Yeah,
at the minute.
that's a great point, and I'll certainly take that away.
Okay. And then finally, I was thinking about the demographic changes that we have, and the population of Northumberland is older and getting older. Now, that doesn't necessarily mean that we should have more coroners' inquiries, but it may do. Because actually, I just wondered, the more deaths you have in total, the more likely you are that those will be referred, and some of those. And therefore, is a degree of planning that needs to be occurring, mapping our population to see if there's a trend. Because within any of the figures, it didn't give me a breakdown of age and the kind of types of deaths which are being inquiries.
We probably could put that age data in.
I'm just thinking in terms of your planning, it may be useful if we can predict that there will be, just by virtue of the population, X number of extra deaths. It means that you can expect X number of extra inquiries, and that needs to be thought about.
No, again, it's a good point, and I know from the IT system that we use, that obviously the date of birth, the age is part of that reporting mandate there. So in terms of the data side of things, which Pam and I have thought about in terms of how we can maximise the use of that, then certainly the age profile is going to be a useful tool for us to use. And in many ways as well, it might not just be to evidence that our demographic is older, and therefore that's impacting on the increased deaths. You've mentioned inequalities, and that that span of healthy life, and the average age, etc., is part of that inequality agenda, isn't it? So yes, I think I'll speak to Andrew about that. We are taking the report to scrutiny in September, and I'll pick up on those two particular issues to hopefully expand upon when we have the next reiteration of the report and we share it further.
Yes. Just on the same subject that you were talking about, I think there's an indication in the figures that shows that in the Northumberland area, only 30% of deaths are reported to coroner, which is the lowest than anywhere else, which to me sort of indicates that it's older people dying naturally.
It's the population split as well. It's the numbers, because North Northumberland is more sparsely populated than South Northumberland, where we have our most populous areas are in the southeast of the county. But yeah, there is that. I mean, we'll be blending that soon, Jeff, in terms of the two districts, because we're going through a formal merger process to blend North and South Northumberland together. And that is just really, we've got a report which is hopefully going to be signed off soon, and it'll go to the MOJ, and they'll progress the legislation to take it into one coroner area. But yeah, it is still shown as, we've summarised it as one figure for the purpose of today, but in Andrew's report you can still see it split as two there. Yeah.
One final question. I think you also mentioned in your report that there is a worrying trend of teenage suicides So what I feel is that now this after Morgan case, the decision-making process switched. You explained from beyond reasonable doubt to balance of probabilities. Do you think it will accelerate the investigation and shorten the investigation period, but it will have no impact on that one?
I don't know if it will sharpen the investigation, if that's the the term that you've used. I think that the Morn case, in that sort of black and white outcome which has been delivered by that case, and where the standard of proof is just that little bit, it's the civil standard, not the criminal standard, that in itself may well lead to a higher number of suicides which are recorded, but it might not necessarily, I hope this makes sense, what I'm trying to say, but it might not necessarily mean that there's more suicides, if that makes sense, just because that's
given
burden.
that the suicide has happened, will you do investigation, you do some investigation, will that be accelerated because of this switch in the decision criteria?
I don't think so.
No, you don't think so.
I don't think
That's
so.
what I was
I don't think it would have an
yeah.
impact on the pace of the investigation.
Yeah.
I think it's purely linked to whatever conclusion may be driven out of that investigation.
Right,
Yeah.
okay. Thank you. Right, there are no other questions, so thank you very much, Karen.
you,
Lovely
no problem.
presentation. Thank you very
Thank
much.
you.
Yes. Health Watch annual report by Derry Nugent. Derry Nugent.
Good morning. I am delighted to provide the statutory report that we are required to do to the Health and Wellbeing Board as part of our role as the independent champion for the users of health and social care services. If most of you will have received a PDF version of this, but I do have at very reasonable rate, i.e. free, copies for you today if you've not already received it. But as I say, I think most of you will have seen and will be knowing what I'm going to be talking about today. The title of the report is Making Care Better Together. And we have achieved what we have achieved this year by working with others. And I am very pleased to say that a lot of those people are represented in this room today. And I think it is undoubtedly true that 6 people can't operate across Northumberland without help from friends. And that's exactly what we do, and that's how we work. So thank you to everyone in this room who has helped make this report possible. While I'm saying thank you, I'm going to start with a major piece of work that we did this year. And again, hopefully most of you will have seen the report. And I have to give a really big thank you to the Northumberland Parent Carer Forum, who came to us with some grave concerns about how children and families, well, children who are autistic and their families, were experiencing trying to access mental health services as well. So there was an existing condition, there was also an additional need. And the Parent Carer Forum came to us and we worked very closely with them, and they helped us design the piece of work which brought forward that report. And I think the reason for me why it was so important, and I think which touched all of us who worked on it, was the phrase that one of the parents said to us, is that we are scared parents of even more scared children. And I think everyone here do not want the children of families in Northumberland to be scared. So it's why we felt it was such an important piece of work, and it was a major plank in our work. And you will see from the report that it was welcomed by the services, so CNTW, the ICB, it was very warmly welcomed. And you'll also see that they refer in there to the plans that are in place, the strategies that are being developed, and a lot of what the parents was talking about are part of those strategies and plans and the transformation in community mental health services particularly. So there is definitely the impetus and the movement towards change. And I think that's really important to address that fear, because I keep coming back to that thing about this concept of fear, which we would all want to see dissipated. So we will be following progress and checking back with the Parent Carer Forum and yourselves to see that that is followed through, because it is such an important piece of work that we think that's happened this year. The other really important piece of work that we did was something which I think every organisation here will be facing, which is how do we engage with young people? It is one of those issues that we all face and we all feel challenged by on occasions. Our young volunteers, we have some young high school student volunteers. They helped us design a survey and a way of delivering it, because we were just going to do it in a very fuddy-duddy way. But they went, no, you don't want to do that, and please don't use those words, and do it in a different way. And we got a fantastic response. So we got 650 people, young people, who responded to our survey, and it was done through schools, and the schools really got on board with it and used it. And I have to say, and we incentivised it so that it was all, we gave a health and well-being prize to the school who got the most responses. And I have to say that I was very pleased to hear from the deputy head at Ponteland High in terms of the impact that the work had had and what the outcome from that piece of work in that school. And the deputy head told us that using our survey had been built into lesson plans, and the campaign that our students had devised fitted very well with the work that their students were doing around having a voice in various aspects of life, from democracy to healthcare. And it was like, wow. So we are, that's a real piece of work where we've really raised that idea of being a citizen and what it means to be a citizen and to be engaged with that cohort. So we're very pleased about that piece of work. And as I say, it was a real collaborative piece of work with the schools. Our work in Blyth was also quite important as well, and you'll see in the report that we worked with the Heart of Blyth, Public Health, and the GP practices in the area to work out why there was a higher than anticipated attendance at A&E by families with small children from that particular area. And it was really an intriguing area for us, because again it was about what impact could we have here? What was our role here? And actually, it came, when we finished the piece of work, it was very clear what our role was. There was a hypothesis at the beginning that the attendance at A&E was, I suppose you would call it, there was a deficit analysis, that it was something about decisions, how decisions were being made, and were the right decisions being made in the right circumstances. But as you'll see in the report, we did a lot of engagement, and with various different communities and groups of parents. But what we heard from families, that they attended A&E because other respected and trusted agencies told them to. So that was really important, because otherwise those services could have started making decisions and devising services on an assumption that wasn't quite correct. Because this was about, if 111 tells you to go to A&E, you're going to go to A&E with your under 5, aren't you? Because why wouldn't you? So that was a really vital piece of information to those designing, promoting services and resources, and we were very happy that our role there was to actually enable that information to be passed across. So there were two pieces of work where I think working collaboratively really paid benefits. So what have we been hearing this year? Anyone want to guess what we've been hearing about this year? Yeah, GP access. So I'm trying not to look at Graham at this stage. Exactly, absolutely. GP access and dentists. There was a brief time during the year where dentistry overtook GP access, but GP access still stays still stays at the top of the things that we hear most about. It's the most common issue raised with us. People provide feedback about phone systems, the availability of appointments, and the importance of continuity of care. So there are three key issues. But something else which is starting to bubble up, and I think, again, this goes back to what I was saying about we can only do this in partnership and what our role is in bringing people together and that convening role we have. We are beginning to, when we're talking to practices, if issues are brought up with us, hearing about did not attend. So those where people have made an appointment but then didn't turn up. And we think that there's an issue there that we can work with practices on to understand what they're experiencing, and also talking to patients to understand their experiences of why people might not be turning up, why they're not turning up. Is it something as simple as how can you phone up to say that you're not going to turn up if you can't get through on the phone? We don't know. So we think there's a piece of work there that we would need to do, but it came out of what we were hearing over the last year. The other issue, as well as dentists, which I'm going to get to in a moment, is pharmacy. And we know that later on we've got a report about pharmacy. We are concerned, not just as Healthwatch Northumberland, but across the Healthwatch network, at the number of community pharmacies that are reducing their hours of services, and we fear what the cumulative effect will be, because it's, you know, a significant service which has been put at the heart of primary care recovery. So where I think we are at the moment with that is that we are obviously keeping a note of where changes are happening. But one of the things that we would particularly like to see, and it's highlighted in the report that came to committee previously and now, is that we would like to see greater emphasis on communication with patients when there's a change, and also on equalities impact assessments. Because I think I think one of the things that we're all aware of is that there are changes in services, more use of digital services and things like that, but we know that's not a total solution for everyone. So we want to make sure that as changes take place in those, that people aren't left behind and left confused and not knowing what to do. We continue to work with local elected members and the local system to find the flexibility for Northumberland, and I'm sure Anne will talk about later about what's happening at ICB level. And I'm really pleased that our work with public health on this issue is helping to influence what the ICB is doing around this issue, and that's really, really important. As I say, for this service which has bubbled up into our attention. Dentistry services, oh yes. Dentistry services are definitely a big issue for us. Access to NHS dentistry, as we all know, is a major cause of concern for residents, and I'm sure elected members here will be seeing that reflected in your ward communications and in your surgeries. And I know that you've been talking to us about it. As of last week, we found ourselves in a position that we were unable to signpost people to any NHS dental practice in Northumberland which was taking new NHS patients. Now that may change, that is it's a fluid situation, but the one that we were aware of has said no, actually that's not happening now. So again, that's a really serious issue for people. We are concerned that lack of practices of taking on NHS patients and provided the preventative services is really going to have an impact on people's health. And that's, I think, as Healthwatch, we will be working with other health watches certainly in this ICB footprint, but I think probably nationally again, but definitely within this one, to find out more about that. Because we know what the situation is, but now what we need to know so that we can pass that on and help to influence what's going on is what that means for people. But sadly, dentistry and pharmacy are issues which cannot be entirely solved by quick engagement, a report and recommendations. That's the model that Healthwatch is supposed to work to. We do some engagement, we write a report, we make recommendations, and something changes. Most of the issues that we're dealing with now are not going to be solved like that, and that's not what we can do. These are national system issues. These are system issues that can only be resolved at a national level. And that's why I was grateful to the Chair for raising the issue about pharmacies directly with the Secretary of State from this Health and Wellbeing Board. And I think that's a really important message from Northumberland that has gone out nationally. Through Healthwatch England, because as you're all aware, we are part of a network of health watches across England, what we have been able to do is keep this issue of dentistry on the agenda of national policy and decision makers. And I would recommend the hearings and the report of the Commons Health Committee, which are available online, videos, very, very good, to see the influence that Healthwatch has at a national level. And it's really important when our national director goes and gives evidence to the Commons Health Committee that she has the evidence from local health watches. So that's why it's really important that we get that flow of information through to us, because then we can flow it up into that national level. Because this only works if we hear what is going on. And that's why I always say to elected members, if people are coming to you, well, they're coming to you all the time, signpost them to us. Or say to them, can I share that information with Healthwatch? Because again, it helps us build that body of evidence, and you can sort out their individual problems, and we can bulk it up and make that system influence work. But so what we've done is this only works because we can get the evidence, as I say, of what's happening. So we get it from you, but where we also get it from is our information and signposting insights. And most of you will hopefully receive our monthly reports about that. However, the big piece of work we do every year is our annual survey. And this year we changed that to an annual conversation. And again, it's all in the report. We also did a survey as well, because we don't want anyone to feel left out. Again, we did this working with community sector partners, and by doing that, we heard from groups who would not normally engage with us. And it also meant that what we heard was richer than before. A survey can only get you so far, can't it? A conversation can get you much, much further. And it also allowed us to use the information more quickly, because it meant we weren't having to wade through, lots and lots of data and do all the analysis and then present it as a quantitative report. We had much more direct information, and I was really pleased, for example, that the conversations and the experiences of families affected by addiction was ready to be fed directly into the new commissioning process for alcohol and drug services. And that was really important to us, because it meant that was that lovely short thing about saying, people said this to us, this is what's happening, who's working on this, you need to know about this. This is something that you need to know about as a commissioner. And again, that was very welcomed, and it was about that impact that we can have sometimes in a short space of time. So we're using all of those things to set our priorities for next year. I thought you might want to know what we're working on for next year, just in case you all want a heads up. So next year we're looking around the two areas of social care and health. Social care, what we're going to be looking at is how the service user voice and involvement is enabled for social care. And we're already having conversations with adult social care team, which is really positive and very welcome. And we're also going to be looking at using pandemic learning about maintaining communications during lockdown conditions in care homes. Again, most of you will know we did a piece of work through the pandemic, where we offered an online forum for relatives whose loved ones were in care homes, and where there was that breakdown in communication because we couldn't get into care homes, and it was all, there were window visits, there were garden visits, there was all sorts going on. But what we know is that even if we never have a pandemic again, care homes lock down every year for different reasons. And so being able to maintain those relationships is actually a live issue. And so what we're doing, we're talking to care homes and saying, right, okay, tell us what worked, and talking to relatives, tell us what worked. So that's going to be one of our enter and view activities for this coming year. In health, no surprise, primary care is going to be our issue, and by primary care I mean GP, pharmacy and dentists, and most of that will probably be working with other health watches. Audiology keeps coming back up. That's going to be an issue, and again that's with obviously working with our colleagues in North Tyneside, because that feeds into Newcastle Hospitals, so we're already working quite closely with them on that. But one of the other things that we are going to do, and we put this in our response to their quality account, is that we are going to be listening out. I think that's probably where we're at the moment. We're going to be listening out for the residents of Northumberland's experiences of using Newcastle Hospital services. It's not an issue that comes up massively, but where it does come up, it comes up. So it's that, that issue about travelling from Berwick or Longfamily, St Long Horton, wherever, to go to the RVI. And what does that mean? How does that work? So again, it's something we're sensitised our ears to that. So we're going to be listening out for that, and we'll obviously be talking to Newcastle Hospitals about that when we've got something that we feel we need to raise. We're also, something that we are starting to pick up a little bit now, and again we're at the stage at the moment where we're gathering information, which is around health visiting services. And again, we're talking to Harrogate and District, to the provider, and we're also starting to put together some information where we've heard how parents are finding health visiting services and their experience of that. As I say, we're in the scoping process, but we're sort of going along with that at the moment, and you will hear more about that. So there are our two main, so social care and health, they're going to be our priorities under our main headings. The themes that we're going to be looking at as well are the experiences of those with isolating experiences or jobs. So where there are additional barriers to accessing services, because access to services is one of the big issues. So that might be, we've done some, you've seen the report, we've worked with the fishing industry around that. But obviously in Northumberland, agriculture is one of the big communities who say to us, actually access is not always easy for us. And we're also talking around to veterans around some of those services as well, and that would be part of our plans. Just coming up to one other issue, one of the other things that we are looking at is about improvement and feedback processes within services. And again, it sort of goes to the heart and the core of what Healthwatch is about, really. We hear from residents who are happy with their care and who are unhappy with what access to services or their care. So we hear both, and what you'll see in a report that we're about to publish in our 6-monthly trend report, that actually the unhappy and happy is starting to, the unhappy starting to come down again and the happy starting to go up as well. So, good news. But what we do find is that people are uncertain how to give feedback or make a complaint. And I know that seems strange when everyone's got it on their website and always leaflets. But we have identified that is not always updated as regularly or as quickly as it might be. Information is sometimes out of date, and it's sometimes difficult to find. So we're going to do a little bit, a piece of work around that. I have to say we're going to start with GP practices. But that's, as I say, that's something we are... I just think it goes to the heart of what we're about. If we're signposting people to say this needs to be resolved, with the service, and there is a process for doing that, and so that it can be resolved at the simplest, lowest, quickest level for you, then that has to be a process that people can find and do that. I mean, allied to that, because why it's important is that we also find that some residents are slightly concerned about raising concerns and complaints. They're not sure what's going to happen. So again, it's about that people feeling it's a legitimate, easy thing to do, and it's the right thing to do. So that's what we're going to do. So the last thing I want to talk about is our annual conversation, because as I say, it gave us better, richer information. But it was also part of our refocusing our work on health inequalities, which I spoke about last year as one of our aims. And it was a contribution to our work and working with colleagues on the equalities plan. As those of you who were at the round table a few weeks ago heard me say at that time, our next step in doing that is to make our annual meeting in October a community listening event. So we're not having a guest speaker. This year, but we are asking senior policy decision makers in strategic partners to commit an afternoon to listen to a range of voices and experiences from people who feel they have not been heard. This is not with a view to respond, so I'm not going to ask you to come along and tell us about your latest strategy or your latest plan, or to say, oh, we really need to know more about that. Can you fill in this survey for me now? We want you to come along and listen, and we're asking groups to think about what issues they have, what they feel they can do about it, and what they might need help with, or what they actually need other people to do. You may recognise that structure from somewhere, but it's an afternoon for listening primarily. We are recruiting the listeners, as I'm calling them, Big L, and we're also recruiting the informed, so that's the community groups of place and interest. And we're talking to the locality coordinators and Thriving Together to identify those communities and people who do not normally have access to your ears. So, I'm going to end on this. Do you have some ideas about whether you'd like to be a listener? If so, bring your ears or bring your issues, because if you know of community groups or people in your localities, and it's like, you know, if you've got two people who've got a particular issue in your ward or your locality who really know what they want to say, then, you know, let us know. Bring your ears, bring your issues to East Bedlington Community Centre on the 18th of October. It's a fantastic venue. You're going to have a great afternoon. If it works, we'll do it again, but we are definitely going to do it. So, 18th of October, East Bedlington Community Centre. Thank you. Any questions?
Thank you very much, David. Thank you. Graham, you have? Yeah, I thought you would have.
Oops. Oh, no, first, thank you, Derry. You are an ever-present person around our system. When there's meetings, when we need patient voices to be around you, you're always there, and so that's down to your personal enthusiasm and your contribution, so thank you very much for that. Hillary's in the room from the LMC, so I'm not going to attempt to say anything much about primary care, other than it's an interesting concept that dentistry and pharmacy are seen as national issues, whereas when we talk about primary care, we focus the issue on general practitioners. And I suspect that's faulty thinking.
That's faulty thinking, yeah.
And therefore, I just wonder if some of the dialogue around GP access should be focused around the LMC and national contracts and what is actually within the gift of primary care to give just now.
Yeah.
And I just wondered if it might be useful to have Derry come and talk at the LMC, but that's not for me to decide because that's Hillary's role.
Yeah.
So thank you.
Thank you. Yeah. No, I think that is a very, very relevant issue. I mean, I suppose the thing that I would say, because I think you're absolutely right, and I think it's very noticeable that's how we talk about the three services. I suppose in my head, I always think sometimes you have more control over some of your things, but that might be me assuming wrongly.
Well, I think you'll find that a lot of, and I'm going to say general practitioners, feel rather helpless and hopeless to be able to do anything about the problem which is perceived as being at their door.
Yeah.
And that just heaps more pressure on them.
Yeah.
And this is adding to the difficulties that we have with recruitment and retention and attracting people who wish to work permanently and give the continuity which our residents need.
Yeah, that's brilliant. I would be very happy to come and do that. Yeah.
Thank you for that input. I think there are two sides to the
Yeah, absolutely.
You want to come in?
Terry, the thing that stuck out in my mind about your presentation today, which shocked me, was you cannot, at this moment, refer anybody to dentists.
Mm-hmm.
And it worries me enormously, as I'm sure it worries everybody.
Mm-hmm.
In particular, it worries me, I'm the Armed Forces champion for Northumberland. We have over 1,500 service families, and that's just the men, that's without families. So if they come here and they're posted here, they're here for 2 or 3 years, I hear the stories time and time again, and by the time they get to see a dentist, they'll be moved somewhere else. And if you cannot refer them, we have a real issue of how we look after these people's dentistry. Mm-hmm. And I know it's beyond our control, but I'm only saying this because I wanted to be sure that we emphasise these issues. And like Graham was saying, it's not something that perhaps we can do, but if we don't flag it up as strong as we possibly can, it's never going to be resolved.
Yeah, and I think those hidden issues are exactly the reason why we're prioritising areas where you think there's not an issue, but there is. And I think you and Peter, as our new chair, definitely need to have a chat.
Okay, thank you.
Yeah.
Thank you. Hilary, yes, please.
Thanks, a really good report and linked to what you're saying about dentistry. And this is a personal rather than probably a professional comment. When you're going through cancer treatment, some of the treatments can only happen once you've had a clean bill of health from your dentist. Yes. And if you don't have that, you can't continue with the treatment. And in terms of inequalities, that may have a big impact because people who don't have much disposable income cannot afford to go to a private dentist.
That is that's a very, very interesting issue and very important, which again is one of those hidden issues. So again, I think that's probably something I want to pick up with you when we talk to you. Okay.
Are there any other questions for Derry? Yes, Rob.
I'm not going to come up with an answer to my next statement, but it's something that I'll be returning to this group to talk about at some point in the future. In that, when we see new homes built in the county or any part of the country, one of the frequent concerns through residents is, well, this is going to make an existing situation worse in terms of GP surgeries, dentists, etc. It is relatively easy to look at the effects on school capacity through new building housing. And there's a very well worked out science of saying if you build 100 new homes, you will need X number of places in different age groups of schools. My difficulty has always been that if we generate funding for additional GPs or dentists capacity, it's fundamentally hampered in its delivery by the fact that these are private companies, effectively. These are independent organisations. And so there are examples in the county as we speak where we've generated funds, via I think called Section 106, to pay for expanded or new GP surgeries, and the local GP surgery does not want to take that up. And we feel we are pushing against, a partially closed door. I understand the tensions in here, but this is a long-term issue, and it was something I think we could do with talking about later. I don't think there's a quick answer to it, but I want to put it on the table as an issue. Thanks.
I just wanted to make the point around inequalities. I think just following on from what you were saying, I think there is a role at a local level. I understand what you're saying about the national picture and system level stuff, but inequalities plays a part in that demand on and actually we should be focusing around best start in life and about that healthy oral hygiene and stuff from that stuff we can do locally, and we can do that at a system at a local level. So I think it would be really interesting if that comes out from October, or maybe how we could work on the stuff that we can fix or can affect.
I agree entirely, absolutely. Yeah.
Okay, I see no more hands. And let's move on to the next item, item number 6. Better Care Fund Plan. So we will be receiving the report and a presentation by Alan Bell, and also making proposals about the sign-up process for future BCF plans. Anything to say? I think Alistair Blair was mentioning something in the last meeting.
Thank you. So, yes, just to introduce myself again, I'm Alan Bell. I'm Senior Head of Commission for the ICB, but in this role, I'm the BCF, or Better Care Fund, lead for Northumberland. I'll give you a bit of background first around Better Care Fund for those who are not necessarily familiar with it, and then I'll go into sort of the local position. I appreciate there's 2 lengthy documents in there, which are national documents. I'll try to summarise and make sense of what they mean, but happy to also take any questions on those as well. So the Better Care Fund has been around since 2015. The guidance itself is a collaboration, so it's been produced by the Department of Health and Social Care, the Department for Levelling Up and Housing and Communities, NHS England, and the Local Government Association. So there's a number of different partners who produce that guidance, and it's fair to say in the past years that guidance has been released quite late in the financial year. This year it's actually been released quite early in terms of the guidance which are required to meet. So it was released in April with some tight deadlines for each place, each area to deliver a Better Care Fund narrative, and there's a planning template which were attached to the papers. Both of those need to be submitted in draft format for a regional assurance process. So just to highlight, there are some quite challenging time scales which I'll go into. That's one of the sort of second requests or asks from the report. So nationally, the Better Care Fund was around and is around meeting some nationally mandated conditions. Ultimately, they're around enabling people to stay well and safe and independent for as long as possible at home, and providing the right care at the right time, at the right place. The direction for centrally has always been to encourage integration between health and care. And certainly there's some metrics which have been built upon over the years. So the metrics which encourage that are looking at avoidable admissions. This year a new metric has been added around falls, and looking at how each area does around falls admissions or emergency admissions, discharge to usual place of residence, residential admissions, and then reablement as well. So that's a very high level. Within that, there's a set of funding criteria. So of that, we need to make, our health needs to make a minimum contribution to social care. Within the Better Care Fund, there's also the Disabled Facilities Grant, which sits separate but is a financial amount included. There's also the Improved Better Care Fund, which is a payment that goes directly to social care. And then a new addition for this year is a winter pressures, or a discharge fund that's been added to the Better Care Fund. So to summarise Northumberland's plan over the last sort of 6 to 7 years, it hasn't changed significantly in terms of the general content, which is just around maintaining existing services and making sure we're integrating between health and care services in that respect. This year it is a 2-year plan, which means there is a little bit more, maybe more of a cushion in terms of understanding what we're doing over the next 2 years. Usually it's a 1-year plan, which doesn't necessarily give as much stability. The main element which is new, which just to highlight, is that discharge fund, and that is on the back of, in November of last year, certainly Department of Health and Social Care, NHS England, government, I think there was a lot of concern around discharging and making sure patients were successfully discharged from hospital into care services. There was an amount of money last year which was given. This year we're given a set of money to support initiatives around that. That money is shared between health and care. In terms of the initiatives which I think it's worth highlighting are, we're looking at additional intermediate care beds from a health perspective. So that's helping where patients may need more intermediate care in the community. So looking at additional beds in that winter or busy winter period. There's some funding to increase the capacity with NIAS, and also looking at supporting complex mental health patients. So there's service we want to continue around that. From a local authority perspective, that funding will be used in part to flexibly support that cost associated with discharge into the care setting. They'll also be looking at a block contract for specialist care home support for older people with dementia. So that's a very high level part. My role, I do work across health and care colleagues to collect that information within the narrative, which I appreciate the narrative is a very lengthy document, and that is ultimately us describing how we're going to work together and also meet those national conditions. The template, the Excel spreadsheet, I appreciate that might be a complex document as well. That has an expenditure element, it has a metrics element to show how we're going to perform or how we think we're going to perform against those metrics and what we're going to do to help support that performance. And then new as well this year is looking at capacity and demand around the system. So that's looking at how many discharges we expect to have and how much capacity we've got in our care setting to actually deal with those discharges. That does cover across Northumbria and Newcastle hospitals in terms of capacity. It's very difficult to predict those numbers from a capacity point of view, as we found, but that information is collected, and there's a return that's done by local authority colleagues every 2 weeks to look at our capacity and how we're managing demand in the system. So that's a very quick summary of what's in the plan. Probably some other things to highlight. So that the ask would be for us to, we've already circulated a draft plan back in June, which went to a regional assurance process. We received some comments back from that regional assurance process, which broadly don't change the outline or the content of the report. That report, or we've made those amendments, and that the attachments that you've got in your packs show those amendments. But we're hopeful that report will get signed off and we'll get formal assurance from NHS England in October time or early October time. As well as set out in that report, it describes the governance arrangements. Now, the governance arrangements and what we've said in the past is we operationally raise issues through System Transformation Board. So the briefing or the ask did go to System Transformation Board back in June time, but also the metrics we would submit on a quarterly basis, and that's how they're reported on a quarterly basis. So System Transformation Board would look at any operational issues, and we'd pick that up. The second point that we were asking for was around those pressing time scales around submission of reports to NHS England, and was to ask for where it's impractical to submit to a formal meeting of the Health and Wellbeing Board members. We would submit a draft by email of planning submissions, and that would get considered by members by email for the Council Statutory Director of Adult Social Care to have delegated authority to sign off if we can't formally take to a Health and Wellbeing Board meeting. So they were the main points to cover, but I do appreciate there's a lot of content on those national documents, but they are nationally mandated, and the format is nationally mandated as well. So every area's got the same challenges in terms of timescales to consider the information and the reporting arrangements. But that's everything from me. Thank you.
Thank you very much, Alan. So, are there any questions to Alan? Yes, Liz.
Thank you. My question is access to the disabilities grant for things like stair lifts, showers, whatever. Apparently the criteria for this fund has not changed in 15 years. Now, the only thing that's taken into account is people's income, not their outgoings. So how many people are missing out on this fund? Surely after 15 years, it's about time the criteria was looked at.
Okay, So that's a very good point. So I'm not directly involved in that element. It's a social care element. However, I will take that back to my social care colleagues, and I'll get back to you with an answer on that particular point. So as I mentioned at the start, the Better Care Fund has a series of different pots of money, and that is certainly one of them that gets drawn in there. But I will get back to you on that specific point, if that's okay.
Graham, you want to come in?
I've always found the Better Care Fund quite a complicated set of stuff to get to grips with about what it actually means. And if you looked at the total spend on social care and the total spend that goes on in hospitals, the Better Care Fund is a relatively small amount of the total spend that we spend on social care. And yet we spend an awful lot of time talking about the Better Care Fund. And the reason for that is, I think, that it's where our agencies all touch each other. So how we spend the Better Care Fund might change whether a person sits for an extra 3 days in a hospital bed or actually is able to get back to independent living somewhere. Or it might be the difference between a care agency having enough staff to get a care package in place quickly or not. Or it might be the difference between an ambulance being able to offload into an A&E department in a timely way, because the A&E dependent is able to flow people through the hospital because it's able to discharge people more quickly. And it probably becomes more important at times of high pressure. So this is why the discharge fund came in quickly at the end of last year, because there was a flu virus coming round that was going to hospitalise an awful lot more people last year, and we saw our hospitals under more pressure than they'd ever been. So there was a thinking that social care and healthcare should be encouraged to work much more closely together, and that's why you have to put these papers together, but that's why they then have to come to the Health and Wellbeing Board, because it's actually a way of forcing the agencies to be more integrated. But it is a lot of discussion about a relatively small amount of the total social care budget. But it just aligns us. Okay.
Yeah, and thinking pragmatically about it, ultimately that's it. It's about encouraging that integration, and what other mechanisms does we call the Centre or NHS England Department of Health and Social Care have to be able to encourage those conversations. I guess in Northumberland, what I would say in the report is we're quite lucky in terms of those relationships are generally very good and very strong. I think in other areas, and I guess cross-border issues does come up a little bit around transfers of patients to and from hospitals and things like that. How you encourage and make sure those conversations are ongoing, I guess I would say it is a challenging topic, but also that ICB is looking at ways of how we make sure actually we're aware of where patients are sitting, for example, in Newcastle, where patients are sitting in Northumbria, which need to be transferred between the hospitals, how we do that and how we support that process. And things like the discharge fund are good mechanisms to enable that. I would say there's a lot of reporting around those things as well, from all from trust and care perspective, which are challenging, but it's part of that beast, I think, to feed.
So I propose that we accept this report. Well, we virtually sign it off. So now we will formally sign it off. Okay, thank you. Yes. Item number 7, notification of closure of 100-hour pharmacy in Cramlington. Hi. Anne.
You may remember that I came in June to warn you that this pharmacy was going to close, and by the time I actually got here for the June meeting, the pharmacy in Sainsbury's had already closed. Even though they were supposed to give 6 months' notice, they didn't work out their notice. This has caused the pharmacy needs assessment, which we wrote in or got signed off last September, is now out of date. However, we can correct it by making what's known as a supplementary statement, which then updates what we said back in September to the current position. So hopefully that then generates a request from somebody to open a new pharmacy. the Pharmacy Needs Assessment Steering Group thought about this long and hard, because if we just said there was a gap in pharmacy services in Cramlington caused by this closure, that we might just get an application for a 9 to 5 pharmacy. And what we actually want is somebody to specifically have in their core hours that sort of time from 6 o'clock in the evening till 9 or 10 o'clock. And that is why we are suggesting to the Health and Wellbeing Board that when we update with this supplementary statement, that we specifically say that we have a gap in services at that out-of-hours period. Because that would mean any application to open a new pharmacy would have to include that in its core hours to get permission to open from the ICB. So we are asking for you to sign off that you are happy for us to put that forward as a correction to last year's pharmacy needs assessment. And while we're doing it, we thought it would be a good opportunity to update all the changes of ownership of the pharmacies. And just to sort of put you in perspective, even since I wrote this report, by the time it's gone through the council sausage machine, getting reports from written stage to being with you today, we've had notification of 2 more pharmacy closures, of a reduction in pharmacy hours in 2 pharmacies, and something like 9 changes of ownership. All the Lloyd's pharmacies have been sold. They are getting out of the business. Most of the people that have bought the Lloyd's branches have bought them at somewhat of a discount. They were anxious to get rid of them and out of the business. So I don't know how healthy the pharmacy market is to attract any newcomers. But we thought it might be prudent to come back in November or December and update you on the closure and reduction of hours in Blythe, in Prudder, in Ashington, and we're just holding our breath and fingers crossed that Tesco don't seem to have been as quick off the mark in applying for reductions of hours. So we still have the Tesco's at Berwick and at Hexham open late, but I really think the direction of travel is that all the 100-hour pharmacies, when they twig onto it, will start closing at 9 p.m. I have been seconded onto a working group with the ICB to look at how ICB can improve its processes for communication of these issues and the sort of people that need to be contacted, because their list of people who need to be contacted when a pharmacy closes is very much predicated on what the situation in community pharmacy was 20 years ago. And the number of people who commission services through community pharmacies for our communities has increased dramatically. And they are not on the checklist to be informed when a pharmacy is going to close. We only get 90 days notice, so by the time I would come back in November or December, we could be looking at even more closures. But with your forbearance, I think it would be useful to come back later in the year and update you on the then current situation. That's all I want to say. Be short and sweet.
There are very interesting points you have come up with, especially replacing the closure of Cramlington, and then monitoring other ones. Yes, we will definitely want you to come back in November. Are there any questions for Anne? No? Thank you. Thank you, Anne. Thank you. Yes. Right. Item number 8, ICB draft John Paul. Hand over to you.
Yes, thank you. It's been quite a long meeting today. Hopefully I'm not going to take you too long with this. North East North Cumbria ICB draft forward plan, joint forward plan, is a statutory document that the ICB has to submit in a couple of months' time. I think the draft is in existence now. It will be amended based on feedback, and there's an aim to submit it towards the end of September. I'm presenting it on behalf of Rachel Mitchison, who can't be here today. She is our director for the ICB in the locality. You may have all been able to read it. It really just sets out the medium-term way that the ICB is going to go about its business in terms of constructing the provider collaboratives, working with CNTW, setting out some of its strategic sort of ways of working. In terms of the Health and Wellbeing Board and how we work in Northumberland, there's not a lot of detail in there about place, but we have our place-based committee, which we call our System Transformation Board, and that's nothing that is in this plan should affect how we go about our business in Northumberland, basically. I'm not going to go through it in any more detail than that today. It's there for your information. You may wish to comment now, which is fine, but I was going to suggest that if you want to feed comments back to me by the end of next week of any sort of reflections or suggestions, what I can do then is take them to Rachel and we can take them through our system just to let the people know who've drafted the document that this is the feedback of the Health and Wellbeing Board. Thank you.
Okay. Yeah, that brings us to the 9th item, Health and Wellbeing Board Forward Plan. Of course, if you have any suggestions for future agenda, items for future agendas, please contact me or Leslie here. Are there any suggestions here for at the moment? Yes, Wendy, please, sorry.
I wouldn't mind an update on the Safe Haven, which was supposed to be opening in Ashington. If CNTW or
yes.
ICB could give us an update on that.
Okay.
I understand the government are ploughing in money to safe havens to take pressure from the police and also accident and emergency. So I would like to see Northumberland getting ahead of the game, shall we say.
Okay.
Thank you.
Yeah, so we will make a note of that and pass it on to Jill.
Thank you.
Thank you very much. Are there any suggestions for future things? Any? Yes.
I'm not sure if this is the right place, but our last meeting at New Biggin, I think Jill's not here today, but Pam is, and I think it was an incredibly successful meeting that we had. And I just wanted to say thank you on behalf of everybody, really, for putting that on.
In fact, I was going to mention
I've just come back from holiday and I haven't had a chance to speak to Paul about what we were going to say about that. So therefore, I'll stop at that and I can let you carry on.
No. It's a solid. I just wanted to mention that one in the urgent business, just a mere mention. And the meeting was excellently well organized and extremely informative, and I really want to thank many of the key players in organizing that meeting. I think one of them is Graham here, and also Jill. So thank you very much. You've done an excellent. Pam as well, of course. Yes, many of them. So I might have missed. So it's really good, and it was a good. I think it's a good effort by the board as well, from our board. Yes, Pam, you want to add something?
I did. Thank you very much. I also wanted to thank everybody because many board members came. They were either facilitators and or presenters and or scribes, and we couldn't have done the day without them. So thank you very much. The initial feedback has been very positive. Today, we are starting, this afternoon, we're starting to go through the feedback to pick out all of the things that we can. We will then repopulate the plan and bring it back via the Inequality Steering Group. So we'll probably bring it back November, December time, by the time we get all of that work done. The two things that are going to happen quite quickly, though, is that the presentations from the day are being edited, is that the right word? Edited into a webinar so that other people can access those very informative and very engaging presentations. And we will have a newsletter come out in September, and that will include a report on the day. So things are still moving. So just if you haven't heard anything for the past month, it's not that things haven't been happening. Things will be coming back to the board shortly.
Thank you, Pam. off, except the one we just dealt with. And of course, last item, just a reminder, next meeting is on Thursday, 14th of September. So take care, enjoy the holidays, if you're still planning your holidays, and have a good time. And let's meet again on 14th of September. So I declare the meeting is ended.